Examination of peripheral vascular disease and gangrene. Examination includes history, physical examination. Physical examination includes local examination and general examination. Then specific investigation. Finally, differential diagnosis. History. History. First of all, age and sex. Number 1, age and sex. Atherosclerosis is obviously a disease of old age. It affects Atherosclerosis is obviously a disease of old age. Old age atherosclerosis. Atherosclerosis. It affects men more often than women. Atherosclerosis. It affects men more than women. Burger's disease, also called thromboangiitis obliterans, is commonly seen in men between 20 and 40 years of age. In men, this is common. Burger's disease, also known as thromboangiitis obliterans. Thromboangiitis obliterans is commonly seen in men between 20 and 40 years of age. Between 20 to 40 years of age. Raynaud's disease. Raynaud's disease is a disease of young women. Diabetic nephropathy is commonly in middle age. Diabetic arteriopathy. Diabetic arteriopathy is commoner in middle age. Number 2, limbs affected. Burger's disease and atherosclerotic gangrene commonly affect the lower limb. Burger's disease and atherosclerotic gangrene. Atherosclerotic gangrene commonly affect the lower limbs. Raynaud's disease mainly affects the upper limb. A patient who presents with superficial gangrene of the finger, the following cause should especially be considered. A patient who presents with superficial gangrene of finger, the following causes should especially be considered. Number 1, Raynaud's disease. The cervical rib. Ribs are mainly thoracic. Scalenus anticus syndrome. Morvan's disease. Morgan's disease. Morgan's disease, painless Whitlow in syringomyelia. Painless Whitlow in syringomyelia. Limbs affected. Number 3, bilateral or unilateral. Bilateral or unilateral. In Burger's disease and Raynaud's disease, the affection is usually bilateral. Atherosclerotic gangrene may be unilateral to start with, but often ends as bilateral disease. Atherosclerotic gangrene may be unilateral to starts and ends as bilateral. Gangrene due to embolism is mostly unilateral. Gangrene due to embolism is usually unilateral. Diabetic gangrene may be unilateral or bilateral. Diabetic gangrene may be unilateral or bilateral. Number 4, mode of onset. Gangrenes due to atherosclerosis, Buerger's disease, and Raynaud's disease occur spontaneously and gradually. Occurs. Gangrenes due to atherosclerosis or atherosclerotic gangrene, then Buerger's disease, Raynaud's disease occur spontaneously and gradually. Embolic gangrene starts suddenly and the patient feels severe pain radiating down the course of artery. Suddenly starts embolic gangrene. Diabetic gangrene may start from the slight trauma, such as caused by careless paring of the toenail or mild infection. Number 5, pain. Note its site, character, radiation, whether it increases in walking or exercise, whether it disappears when the exercise stops, and whether it becomes worse on application of warmth when the circulation of the limb is impaired. 2 types of pain are noticed. Number 1, intermittent claudication and rest pain. Intermittent claudication. Intermittent claudication. Though literally claudio means I limp, yet the term claudication is used here to describe the muscle pain due to accumulation of the excessive P substance owing to inadequate blood flow. Here the term claudication is used here to describe the muscle pain due to accumulation of excessive P substance owing to inadequate blood flow. It is a pain in the muscles, usually the calf, and it described by the patient as a cramp. The patient as a cramp. Of course, the site of pain depends on the level of arterial occlusion in the foot in Vergus disease, in which the arterial occlusion is mostly in the lower tibial or plantar arteries. In the lower tibial or the plantar arteries. In the calf, in case of arterial occlusion in femoropopliteal junction, which is very common. In the calf, in case of arterial occlusion in femoropopliteal junction. Which is very common. In the thigh, when the occlusion is at the opening of superficial femoral artery, and in the buttock, in case of thigh, calf, then calf, in case of thigh, in the thigh when the occlusion is at the opening of superficial femoral artery, and in the buttock in case of occlusion in the bifurcation of common iliac artery or the aorta. The pain develops only when the muscles are working. The pain disappears when the exercise stops. The patient often complains that after walking a distance called the claudication distance. The pain starts. Sometimes, if the patient continues to walk, the metabolites increase the muscle. If the patient continues to walk, the metabolites increase the muscle blood flow and sweep away the P substance. Produced by the exercise, and pain disappears. This is called grade 1. If the patient continues to walk, the metabolites increase the muscle blood flow and sweep away the P substance produced by the exercise, and pain disappears. The pain continue. Grade 2. Pain continues, and the patient can still walk with effort. Grade 2. Grade 3. But mostly the pain compels the patient to take rest. Pain compels patient to take rest. These are called Boyd's classification. Rest pain. This is called claudication pain. Intermittent pain. Now, rest pain. This pain is continuous and aching in nature. This pain is continuous and aching in nature. This pain seems to be due to the ischemic changes in the somatic nerves. It is the cry of the dying nerves. It is the cry of the dying nerves. The pain is worse at night, gets aggravated by elevation of the leg above the level of the heart, and is relieved by hanging the leg below the level of heart. It usually affects the most distal part first, that means the tip of the toes. It usually affects the painful part becomes very sensitive, and any movement or pressure cause an acute exacerbation. It is the cry of the dying nerves. Cry of the drying nerves. Number 6, effects of heat and cold. Effects of heat and cold. Application of warmth will increase the symptoms of arterial occlusion. Raynaud's phenomenon, intermittent attack of pallor or cyanosis, is often seen in Raynaud's disease and sometimes in Buerger's disease. Raynaud's phenomenon, in which intermittent attack of Raynaud's phenomenon, intermittent attack of pallor or cyanosis, intermittent attack of pallor and cyanosis. Intermittent attack of pallor and cyanosis is often seen in Raynaud's disease and sometimes in Buerger's disease. In Raynaud's disease, a number of attacks can be seen. Each attack is comprised of 3 stages. In Raynaud's disease, a number of attacks can be seen. Each attack is comprised of 3 stages. Number 1, local syncope. Number 2, local asphyxia. And number 3, local recovery. Local syncope, in which the affected digits become cold and white with tingling and numbness. These changes are due to spasm of the digital arteries. In Raynaud's disease, a number of attacks can be seen. Each attack is comprised of 3 stages. Local syncope, in which the affected digits become cold and white with tingling and numbness. These changes are due to spasm of the digital arteries. Local asphyxia, in which the white digits turn blue with burning sensation. The white digits turns blue. With burning sensation This changes is due to slowing of circulation and accumulation of reduced hemoglobin. This change is due to slowing of circulation. This disease is due to slowing of circulation and accumulation of reduced hemoglobin. Local recovery, in which the bluish discoloration gradually disappears and digits remain normal color due to release of spasm of digital arteries. Now normal color. Such attacks are repeated till in the end passage of the superficial ulceration and gangrene appears at the fingertips, which is known as local gangrene. Now, paresthesia. Number 7. Paresthesia. When the muscle pain begins, the patient often feels numbness, pins and needles and other types of paresthesia in the skin of the foot. This is due to shunting of blood from the skin to muscle. Number 8. History of superficial phlebitis. This is characterized by swelling, redness and minor pain in the affected part. It occurs in high proportion of cases of Buerger's disease. It is characterized by swelling, redness and minor pain in the affected part, and it occurs in high proportion of cases of Buerger's disease. Now, involvement of other arteries. Number 9. Involvement of other arteries. Inquiry must be made if there is complaints of fainting, transient blackout, chest pain, weakness or paresthesia in the limbs, blurred vision, abdominal pain to exclude occlusive arteries disease anywhere in the body. Number 10. Importance. Due to failure in erection is not uncommon symptom in case of bilateral internal iliac artery occlusion. In case of bilateral internal iliac artery occlusion. Number 11. Past history. The patient with arterial occlusion may give a history of previous cardiac attack or embolic syndrome. The patient may be diabetic. There may be history of exposure to cold, frostbite, etc. The patient with arterial occlusion may give a history of previous cardiac attacks or embolic syndromes. The patient may be diabetic. There may be history of exposure to cold or frostbite, etc. Personal history. Number 12. Personal history. Excessive smoking has been incriminated as causing thromboangiitis obliterans and worsening atherosclerotic disease. Excessive smoking has been incriminated as causing thromboangiitis obliterans and worsening atherosclerotic disease. Number 13, family history. It is amazing to know that arterial disease, particularly atherosclerosis, is often familiar. Family history. Atherosclerosis is often familial, and if you practice the habit of asking if the members of the family are affected with the same disease or not, you will find quite a few are or are suffering from this disease, atherosclerosis. It is the common familial disease. History done. History includes 13 points. Number 1, age and sex, then limbs affected. Number 3, bilateral or unilateral. Number 4, mode of onset. Number 5, pain. 6, effects of heat and cold. 7, paresthesia. 8, history of superficial phlebitis. 9, involvement of other arteries. Number 10, importance. Number 11, past history. Number 12, personal history. Number 13, family history. Physical examination. Considerable constitutional disturbance may be observed in severe acute ischemia from embolus and in grease gangrene. There may be lowering of blood pressure and increase in the pulse rate in both these conditions. In chronic ischemia, there is not much constitutional disturbance. Physical examination includes local examination and general examination. Mainly we will study about local examination. It is important. Local examination. Local examination includes inspection, palpation, and auscultation. Inspection, palpation, and auscultation. Number 1, inspection. Inspection includes change in color, signs of ischemia, Burger's postural test, capillary filling time, venous refilling. Number 1, change in color. Change in color. Change in color is the most noticeable feature of an ischemic limb. To detect minor change in the color, the clinician should put the affected limb and its fellow side by side. Marked pallor is a remarkable feature of sudden arterial obstruction as seen in case of embolism or in spasm of the arterioles in Raynaud's disease. Marked pallor is a remarkable feature of sudden arterial occlusion in case of embolism or in spasm of arterioles in Raynaud's disease. Congestion and purple-blue cyanosed appearance are the characteristic features of severe ischemia and pregangrenous stress. Congestion and purple-blue cyanosed appearance. Congestion and purple-blue cyanosed appearance are the characteristic features of severe ischemia and pregangrenous stress. Severe ischemia and pregangrenous stress. As soon as the limb is elevated, it becomes pallor. Number 2, signs of ischemia. Signs of ischemia. While examining a case of arterial insufficiency, one must know the signs of ischemia. These are thinning of the skin, diminished growth of hair, loss of subcutaneous fat, shininess, trophic change in the nails which become brittle and show transverse ridges, and minor ulceration in the pressure area such as heel malleoli, ball of the foot, tips of the toes, etc. While examining a case of arterial insufficiency, one must know the signs of ischemia. These are thinning of the skin, loss of subcutaneous fat, diminished growth of hair, shininess, trophic changes in the nails which become brittle and show transverse ridges, and minor ulceration in the pressure area. Brugger's postural test. Number 3, Brugger's postural test. This test must be carried out in broad daylight. The patient lies on his back on the examining table. The patient is asked to raise his legs one after the other, keeping the knee straight. The legs of a normal individual remain pink even if they are raised to 90 degree. Normal, pink. But in case of ischemic limb, elevation to a certain degree will cause marked pallor and veins will be empty and guttered. But in case of ischemic limb, elevation of a certain degree will cause marked pallor and veins will be empty and guttered. The angle between the limb and the horizontal plane at which such pallor appears is called Brugger's angle. The angle between the limb and the horizontal plane at which pallor appears is called Brugger's angle or the vascular angle. Brugger's angle oblique vascular angle. A vascular angle of less than 30 degree indicates severe ischemia. Less than 30 degree vascular angle less than less than 30 degree indicates severe ischemia. If the feet do not become pallor and occlusive arterial disease is suspected, the following addition may be performed. The elevated legs are supported by the examiner while the patient flexes and extends his ankles and toes to the point of the fatigue. If there is occlusive arterial disease, the sole of the foot assumes cadaveric pallor and veins of the dorsum of the foot become empty and guarded. The feet are now lowered so that the patient adopts sitting posture. Within 2 or 3 minutes, a cyanotic hue spreads over the affected foot, whereas no changes will observe in case of healthy limb. This is due to cyanotic congestion. Number 5. Capillary filling. Capillary filling time. After elevating the legs, the patient is asked to sit up and hang his legs down by the side of the table. A normal leg will remain pink. A normal will remain pink as it was during elevated position, but an ischemic legs will first become pallor. Ischemic legs will first become pallor when elevated and gradually becomes pink in horizontal position. Gradually becomes pink in horizontal position. This changes of color takes place slowly and is called the capillary filling time. In severe ischemia, it takes about 20 to 30 seconds to become pink. Then the ischemic limb again changes color and becomes purple red quickly. This is due to the filling of the dilated skin capillaries with deoxygenated blood. Number 5. Venous refilling. Number 5. Venous refilling. After keeping the limb elevated for a while, if it is then laid flat on bed, there will be normal refilling of the veins within 5 seconds. But in ischemic limb, it will be delayed. If a normal limb is raised to about 90 degree, there will be gradual collapse or gartering of the veins. But in ischemic limbs, the veins are seen collapsed either in the horizontal position or as soon as it is lifted to even 10 degree above the horizontal level. 10 degree above the horizontal level. In established gangrene, the following points are noted. In established gangrene, following points are noted. Extent and color of the gangrenous area. Extent and color of the gangrenous area. This is important to ascertain the level of the arterial occlusion. In gas gangrene, besides the typical odor of the sulfurated hydrogen, the muscle also changes their color to break red. In gas gangrene, besides the typical odor of the sulfurated hydrogen, the muscles also change their color to brick red, green or even black according to the stage of the disease. Green / black. Type of the gangrene should be noted, whether dry, The parts become mummified or wet and putrefying as seen in the diabetic gangrene. Wet, whether dry, wet and putrefying. Line of demarcation. Line of demarcation is often seen between the dead gangrenous part and the normal living limb. In gangrene, due to all the conditions, this line of demarcation is poorly marked except in Einham. In this condition, there is a linear dipping groove at the base of the little or the fourth toe, which is the pathognomic fissure. It is the pathognomic fissure. It is always advisable to observe the limb above the gangrenous area. Limb above the gangrenous area. This may be congested, edematous or pale. This may be congested, edematous or pale, which indicate the possibility of later involvement of this area. There may be black patches which indicate skip lesion. There may be black patches which indicate skip lesion.